Are we good? Hey, good afternoon. This is Dr. Bill Bird. I'm the Chief Medical Officer here at CGH Medical Center. Welcome to our Facebook Live broadcast on Thursday, September 24th. Hey, I have Dr. McKay with us again. You
Hello.
remember Dr. McKay, I'm sure.
Good afternoon.
Dr. McKay is a cardiologist. He's the section chair of cardiology. He kind of oversees our cardiologist here at the hospital. So glad to have you again today. And we get done. By the way, Dr. McKay is on call, so we'll have him as long as we can have him. And if he gets called away, we'll pivot. And then when Dr. McKay gets done, we have the manager for our Cath department, Chico, is going to be with us as well. So what I wanted to do today, I have some COVID questions, and as always, I will get to those. I'm going to kind of go into a little bit about heart stuff first, and so towards the end of this broadcast, we'll kind of go into the COVID situation and some questions that all of you have sent me about COVID stuff. As we're talking, if things come up that you want to ask Dr. McKay about, make sure to send those to us ASAP, because if I get those, I will definitely ask him, and we'll get answers to your questions. So while we're waiting for any of those, a couple questions that I want to start with. And by the way, we're going to talk about our cardiac catheterization lab. So where we do these procedures down in our Cath lab is what we call it, for folks who have heart issues. So first question, what's the difference between an angiogram and angioplasty?
Well, thanks for having me today. It's
Yeah, you
great
bet.
to be back. I enjoyed our last time together, 2 or 3 months ago. So happy to be back today.
Yeah.
Thanks for inviting me. So an angiogram is a study where by catheter, we inject, usually by catheter, in cardiology it's always by catheter, we inject dye into an artery or a vein, and we visualize that, looking for any sort of changes in anatomy or obstructions or things like that. So that is an angiogram. That's relatively simple injection of dye into a vessel, blood vessel.
Just a picture. You're taking a picture of the blood flow in real time through
Just
the heart.
a picture, yep.
Yep.
And it's basically a movie, short.
Yeah.
Each picture is maybe 2 or 3 seconds.
Yeah.
And when those pictures are being taken, a camera is rotating around you, taking various angles of the vessel with contrast in the vessel. So we can kind of make a image, a three-dimensional image of or a three-dimensional rendering of a two-dimensional picture. So one angiogram picture will be dye injected into the artery in one angle, and then a second angle, and maybe a third angle. So we're kind of reconstructing by 3 dimensions, two-dimensional pictures, trying to get an idea of an obstruction. Is there an obstruction? Is there some sort of an unusual anatomy that's causing a problem? So that's an angiogram. Very simple to do, usually only takes 5 or 10 minutes to do that. An angioplasty is, angio means vessel, plasty means treating in some way. Angioplasty is basically treatment of the vessel. It's kind of a generic term. A lot of things encompass the term angioplasty, but for simplicity's sake, it's usually a balloon. The balloon is on a catheter, and that catheter is in the blood vessel, and angioplasty is when we do something to the vessel. And probably in the simplest terms, like a balloon on the catheter, the balloon inflates, kind of pushes a blockage out of the way. That's angioplasty. So back in the late 70s, early 80s, if you had a heart attack, that was really the only option, would be angioplasty. Before that, there was really no option at all back in the 70s and before. If you had a heart attack, you were on bed rest for 2 or 3 weeks in the hospital and hope for the best, other than good medical therapy.
Yeah.
So we've come a long time, even in my lifetime and since I've been a cardiologist, at increasing what we do in the cath lab. And so it's kind of exciting to be in this field, because the field is just advancing so quickly.
When you started, you're probably too young for the bare metal stuff as the standard when you started?
So when I first started doing
so right now, just so folks know, they don't use just a bare metal stent. They use
occasionally we do,
Okay.
but more often than not, we use a drug-coated stent. the first generation drug-coated stents had some issues with them. Those have been revised, and now we're on the second generation, and the technology continues to get better and better. So the first generation drug-coated stents did have some problems. Those are no longer implanted and haven't been for several years. Some people still have them in place, and for the most part, if they haven't had any issues with them, and by this point, they're probably not going to.
Yeah.
But I would say 90% of what we put in, at least 90, if not more, are drug-coated stents, and it's really good technology.
Yeah, good. So how much training did you have to be able to do these procedures? I think I asked you a few months ago, but like how long after?
My general cardiology training was 3 years. I did
Okay.
that at National Naval Medical Center / Walter Reed. That
Okay.
was 3 years. And that's just the basics of being a cardiologist, where I learned how to I learned how to do the diagnostic portion of,
Yeah.
of an angiogram, but not any interventions. And then in general cardiology, you learn how to read echoes and nuclear studies, and of course take care of the patient in the clinic. And then for interventional training is another year. Sometimes people do a second year that's not accredited, and that's real luxury, and not many people do that second year just because it's really not funded. But it's 1 year of dedicated interventional training. I did that at Duke University in Raleigh, Durham, North Carolina, and that was 1 year.
Okay.
And then after finishing that training, that's kind of just getting the start. You know, you kind of have to, that's the keys to drive the car, basically, at that point. And I think about the interventionalist that I am now compared to when I finished training. It's kind of night and day, just the experience that's involved in becoming a kind of a seasoned interventionalist.
Sure.
Really, you need a certain number of cases under your belt.
Sure.
Like 750 would be probably that's the mark where you really start hitting your stride.
750.
750.
Okay.
And I'm about just over 1,000 at this point. So it's kind of a long process.
Yeah.
And you're really mid-career by the time you really become competent. For the most part, there are exceptions, of course. But
Yeah. Yeah, good. So one of the newer things I know that wasn't part of your training is this piece of equipment that we have here at the hospital. We've been using some called an Impella. It's spelled Impella. For those of you who want to look that up and kind of learn a little bit more about it, but yeah, in a nutshell, I think this is kind of interesting, the technology that you're using in our Cath lab here in Sterling. Can you talk about it a little bit?
Sure. Impella's been around about 10 years, and it came around when I was at training at Duke University. And we were really excited because we had used that device there. Probably I did 4 or 5 cases there, and it was very exciting at the time because nothing was like it before. It's basically a large pigtail, so it's a catheter-based therapy. That pigtail is a catheter that kind of looks just like as it sounds, a pigtail, kind of curly Q on the end of the catheter. And that allows us to usually give a nice bolus of contrast without injuring any sort of vessel. And that's why it's kind of curled up and has a couple little ports to distribute the pressure, the dye. Well, the company that developed Impella developed a little bit bigger of a pigtail catheter that instead of is used to inject dye into the heart, it's used to pull blood out of the ventricle, across the aortic valve and into the aorta, which really supports the heart, unloads the heart, and allows us to perform high-risk angioplasty with greatly reduced risk, and sometimes is used in a situation of when somebody's in shock, like they've had a bad heart attack, and the heart can no longer perform adequately to keep the person alive. This Impella pump can oftentimes, in that critical situation, which fortunately doesn't happen that often, but when it does happen, this can be a life-saving maneuver.
Yeah.
And it's fairly simple. We've done, Chico, how many have we done now? Maybe 10 here.
Okay.
And we've had no issues. It's been pretty
That
straightforward.
is really cool. So, in layman's terms, it's essentially just something that supplements the pumping that your heart would normally do, but for a heart that's under stress.
That's right. It provides cardiac output, which is every time your heart beats, it moves a certain amount of blood, and we characterize it how much blood per minute. And this can significantly, depending on the size of the Impella that's put in, really augment your cardiac output. That is, do the function of.
Because if you don't pump blood, you don't move much.
That's right. at all.
Not at all. Yeah. So it's a good thing to have an Impella if you need it. Okay.
Yep.
So I wanted that kind of be the segue into kind of what would you say the latest and greatest in that you're using right now in the Cath lab that you may have not used when you got out of training?
So I'm excited about the Impella. We brought the Impella here, and I think that that's been a great addition. We do atherectomy here. I'd like to do more here.
Can you kind of briefly, what's an atherectomy?
So atherectomy is basically a roto-rooter technique of a valve or of a artery that's heavily calcified, like a valve that's kind of like a corroded pipe, if you will. And
yeah.
if the more corrosion that's there, the harder it is for blood to get through. And if you have a lot of corrosion, a lot of calcium usually, and calcium is part of the atherosclerosis that can occur in the arteries. The more calcified, more corroded it becomes, the harder it is for blood to get through, and the harder it is for us to fix it by catheter-based therapies. So atherectomy, that is removal of that calcium, is something that we do. That would be under the umbrella of angioplasty.
Because a balloon would be pretty tough. If you have hard plaque, it'd be pretty tough.
Sometimes a balloon won't do the job.
Yeah.
Even if you can get the balloon there, sometimes you can't even get the balloon there because there's so much calcium there. Getting the wire there is a different kind of a little subset. That can be challenging, but not as challenging as getting other devices into the area that we want to treat. So what an atherectomy catheter, it's over a catheter again. The atherectomy catheter goes down, there's a little, basically a burr that can get rid of the calcium, or not get rid of it, but modify it to soften up the vessel. And then once the vessel's softened, then we can deliver balloons and stents and treat the area that we need to much more effectively. So that's a game changer as well. That's not new, that's been around for a while, but it's probably newer to bring it to CGH, a facility this size.
Yeah.
And so part of my job as a cardiologist when I take care of you is to make sure that I cover the risks for you and don't put you or the facility in jeopardy by doing something that we shouldn't do here. So putting an Impella catheter in is one thing, treating the vessel appropriately, maybe with atherectomy, oftentimes can make the difference between a successful and an unsuccessful procedure.
Yeah. Good. Anything else in terms of devices or stuff, procedures that you do a little differently than you used to when you started out?
Well, for legs, we have drug-coated balloons, which helps reduce...
so if you're doing someone has blockages in their legs...
That's right. So that's only been around a couple of years.
Okay.
So a balloon, like an angioplasty balloon on a catheter, is impregnated with drug that we usually put on a drug-coated stent, for example. Those balloons in the legs can go down and make a big difference as to whether angioplasty only with drug can help reduce the chance of recurrence of the blockage in that area. And for the legs, it works very well. That is not approved to do in the heart yet. It is over in Europe. But I'm wondering, what the kind of the lag is.
Yeah.
I think it may be an efficacy issue, a usefulness issue, but to be determined.
Yeah.
Some things that we don't do here that are being done, and we probably won't do them here without having a cardiothoracic surgeon, would be transcatheter aortic valve replacement, mitral clip, that is if somebody has a lot of mitral valve regurgitation, a clip can be put on that mitral valve in certain circumstances to treat that mitral valve regurgitation as backflow through the valve. So that would be one. Transcatheter aortic valve, another. That's catheter, basically aortic valve replacement by catheter.
Yeah, that's been a game changer.
Game changer, especially elderly folks who've already been bypassed before, or don't have the tolerance for an open heart procedure or the willingness. That's a game changer. Fortunately for that valve is a win-win-win. Patients at high risk do better, patients at intermediate risk do better, and patients even at low risk. If you're 50 years old and you have a bicuspid valve and that valve needs to be replaced, you can select to have a catheter-based replacement. And it's not inferior to surgical, it's superior, which is
wow.
Statistical interpretation of the data. So that's very compelling.
Yeah.
That's usually done with a cardiologist and a cardiothoracic surgeon together. Genesis, I think, and Davenport is one of the areas that we send folks to.
Sure.
And then the third issue is, again, structural. we won't do here is placement of a left atrial appendage occluder device. So the left atrium is one of the chambers of the heart when you
Is that the Waterman? Is that what you're talking about? Is that the Waterman device? Is that what you're talking about?
No.
Okay.
The left atrial appendage is where the blood can collect
Right.
and clot. And that clot, in certain circumstances, like atrial fibrillation, you're thinking of Watchman.
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 Yes, that's what I was thinking.
So yeah, that's the Watchman. So that's the most.
So some folks may have heard of Watchman, yeah, because I've had some patients that have had those.
So that's a good. That's a niche therapy, but when that niche is there, it's really helpful. So let me just, without getting too far into the details,
Yeah.
just give you a little bit of an overview. So this is used when patients have atrial fibrillation, which is very common, irregularity of the heart rhythm, predisposes them, depending on the risk factors, for stroke.
Right.
So usually a recommendation is for long-term anticoagulation, so warfarin or
Some sort of blood thinner.
some sort of blood thinner. Well, not everyone can take blood thinners, or not everyone is willing to take them. This is where the Watchman device, that's where the niche is.
Yeah.
So, like the few cases that I'd seen recently, somebody with atrial fibrillation, they may have already had a stroke before, they have atrial fibrillation, there's an indication for them to continue the anticoagulation, but they have a GI bleed. This would be the perfect case for that. You put the Watchman device in, as
Sure.
long as that goes well and includes the appendage, which is that little pocket where the
Yep.
blood can collect, then you can reasonably stop their anticoagulation. Therefore, they're not having a GI bleed, the blood's
Right.
not thin, and they're prevented from having a second stroke.
Yeah.
And that's guideline therapy. It's approved. So
Yeah.
that's exciting.
Yeah, that is. You know, you mentioned heart surgeons and having the backup of a heart surgeon. And I think, you know, for folks who are watching, one of the things that you always hear about is, well, someone came in and they had a stent placed, or they had 3 stents placed, and then they went back home and they're, you know, doing well and everything. Some people come into the hospital and have an angiogram and end up somewhere else to have an open heart surgery done. Who gets the stents, and in general, who gets the stents and who gets the open heart surgery?
Sometimes it's confusing or challenging to decide which is the better option. So if I do an angiogram on somebody and they have semi-complex anatomy, like more than one blood vessel that has a blockage,
Yeah.
a lot of factors go into deciding whether they should be better. Would they be better served by bypass or by stents? Sometimes I'll enlist the patient in that decision, so shared informed decision making
Yeah.
with the patient. And but even in that situation, I'll usually give them my opinion as to what I think would be best long-term option for them.
Yeah.
There are calculators that we use. The Syntax trial gives you data on whether patients do better with bypass or whether they do better with stents. Some technical features for me would be, how many stents would they need? If I'm going to do it by stents, how many stents? If it's a lot of stents, then I'm kind of thinking bypass surgery.
So does that mean like if you have a bunch of vessels, kind of
bunch
more?
of vessels, bunch of stents?
Yeah.
And the more stents you're going to put in, the harder it's going to do them all at once.
Yeah.
And then there's a increased risk for having them come back for
Yeah.
repeat procedures. But it's a give and take. You know, surgery's not a panacea either.
Sure.
Sometimes with surgery, though, after the fact, we can go in and stent them, or stent a blockage if it needs it. Sometimes the bypass graft doesn't work, whether it be 1 year or 10 years down the road, then we have to stent either the graft or the normal vessel. You can have had stents in an artery, or 2 arteries, or even 3 arteries, and then your stents restenose, we call it, scar tissue within the stents, and if that occurs 2 or 3 times, sometimes you would be better served by having bypass surgery instead of another stent.
Mm-hmm.
So that's really where my job is having the best interests of the patient.
Yeah.
And deciding. And then I usually don't make that decision without discussing it with the patient first.
Yeah.
And say, this is what I think and this is why I think it.
Yeah.
And then if they disagree, people have disagreed before, and as long as we've had our eyes are open as to what the options are, and we've agreed, and then I will usually follow their wishes.
Yeah.
And we've had, there are times when I've recommended bypass surgery to somebody and they just didn't want their heart open. So I've done angioplasty and stent placement, and they've done great, and everyone was happy. So it's not.
Yeah. So the answer is the answer is not an answer for sure.
It's not absolute.
Yeah.
And that's where the practice of medicine comes into play. And I think a very important thing is voicing your opinion as what you want when you're told of whatever your results are. And as long as you have your facts in line and you're aware of what your options are, then you'll be happy with the decision.
Last I read, there was definitely a trend towards diabetics perhaps doing more of the open heart than the stents. Is that still the case?
Yeah, that's old data,
Okay.
but it's accurate data, and we see it in the Cath lab now. So if I see somebody who has a couple vessels that are blocked, they're diabetic, especially if they're poorly controlled but diabetic, that's somebody who their stents are probably going to not hold up over time, or they're going to develop new lesions. If they have more 2 or 3 vessel disease, they're diabetic, and they have a compromise in how well their heart squeezes, that's traditionally somebody who would do better with bypass surgery than stents.
Right.
But in the trials in general have looked at this, and it's really comparable across the board, all folks, so population, not segments, but across the board, it's comparable, whether surgery or bypass. But there are little subsets, and that's one of the ones that you mentioned.
Okay.
And another would be disease complexity.
Okay.
So if it's going to take 3 procedures for you to get all your stents, and you're going to need 10 plus stents, I usually don't advise that. Yeah.
What's the latest on these stents that you're putting in now that have they're coated, but they still have a tendency to plug up? So you put people on blood thinning medicine to help them with that.
Yeah. So
what's the recommendations lately on all that stuff?
So if you've had a heart attack, or what we call in medicine acute coronary syndrome, so you've come in with an unstable syndrome, you've had it usually that's marked by a troponin elevation. That's a blood test that's checked when you come into the hospital. It's 12 months is the recommendation for what we call dual antiplatelet therapy. So it's going to be aspirin and clopidogrel, aspirin and Efient, or aspirin and ticagrelor. More often than not, class 1 recommendation, preference for ticagrelor now, because that has the best data with it.
What's the brand name of that?
Brilinta.
Brilinta.
So
okay.
aspirin and Brilinta is what you're going to be put on. And if it's put in the situation of an acute coronary syndrome, it's a year.
Okay.
So a lot of times we get a question, we've done that, person needs surgery, elective surgery, 2 or 3 months later. The recommendation is to wait on that surgery.
Okay.
That's an acute coronary syndrome. If it's in a stable situation where it's not an acute coronary syndrome, then it can be 6 months. Or if in a pinch, 3 months.
Okay.
So it depends on the situation in which that stent was placed.
Okay.
That's the newer drug-coated stents.
And I know it seems like I remember in one of our journal clubs, Steve, that you had meant there was something that came out that for a while people were doing 3 different anticoagulant, and they went away from that to just the 2.
So that's so-called triple therapy, and that's recently been studied in the Augustus trial, and that's if you continue that, there is an increased risk of bleeding with 3 agents. Intuitively, it makes sense, and it's true. But you can do that for a month, then switch. Like if you have atrial fibrillation, and you've had a stent placed, we usually will continue on all 3 things. So like Eliquis, aspirin, Brilinta, or Eliquis, aspirin, Plavix, clopidogrel, for a month. Then you drop the aspirin. So the aspirin is the one that you drop, and you continue clopidogrel per the studies. Clopidogrel, and then the antithrombotic agent. Okay. So that's important.
Yeah. So I think the thing for folks listening is just, as you talk with your physician, if you're on 3 blood thinning medications for more than a month or so after you've had your heart procedure done, it's probably worth a conversation to say, hey, can we go down to 2? And
that's right.
What 2 could we go down to?
Absolutely right.
Okay. Yeah. Good. I'm pushing on time here on Dr. McKay, so I'm going to ask. Okay, we have enough time questions probably to go another half an hour, so I'm just going to kind of cut this because I know you're on call and I don't want to take too much of your time. But you know, one of the it's nice to have these advanced procedures here at the hospital. We want those. We're glad to have them. But my goal as a patient, and the goal I'm sure of the folks who are watching, is to not go into that cath lab and to try to stay out of it as much as they can. So just talking in terms of trying to prevent having to go in there, in other words, to prevent blockages in the blood vessels in your heart, is there in a broad brush stroke, a group of patients that you would say should be on stuff to prevent them from having to go in there, like aspirin, cholesterol-lowering medication called statins, certain blood pressure medications to keep their blood pressure controlled? What are your thoughts on that?
So you just described my clinic that I hold every day, which is basically where I'm managing these, what we call risk factors. So probably number one, stop smoking. If you have a heart attack and it's 2 a.m., there's a good chance that you're a smoker.
Really?
It just seems to me that that's the case, and that's, I've been in practice now for 15 years. That's what I see.
Okay.
It's mainly smoking is the fuel that drives the fire. So that's number one. Number two, making sure your blood pressure, if you have high blood pressure, that's controlled. If you're on a medicine for blood pressure, it needs to be the right dose. If you need 2 medicines, make sure that whatever it is, your blood pressure is controlled. If you have high cholesterol, that's controlled.
Let me ask you about that, the cholesterol side of things. Is it still you want a bad cholesterol below a certain number?
So pretty much the LDL, which is the bad cholesterol,
yeah,
the lower the better.
Okay.
So I just had a discussion with somebody yesterday who has coronary disease, who had an LDL of 90. They were on a statin, and the discussion was whether we should drive that LDL lower by increasing the statin to further reduce his risk. He'd already had bypass surgery. He'd already had a stent placed. He was interested, and so we increased his dose of statin, that's good when we can do that. A lot of people aren't tolerant of statins, though. So there are alternatives, and those alternatives are good alternatives. We didn't always have them before, we do now.
Okay. Yeah.
So,
yeah, okay.
So it's basically risk factor
Yeah.
reduction or modification.
Yeah.
That is controlled behavior, smoking, high cholesterol. If you're a diabetic, making
Yeah.
sure your diabetes is under good control.
Yeah.
Those are the main things.
If you haven't had any heart disease so far, who are the folks that should be on aspirin, if anyone? And that's a baby aspirin, I would say.
So, you know what, I get this question frequently, and I don't, based on recent data, I don't prescribe aspirin to everyone. I look at their risk factors, and I look at their CVD risk score. And a CVD risk score is something that I would calculate in the clinic and find out what your 10-year risk of a cardiovascular event is. And if that event is of a certain threshold, I usually will recommend a low-dose aspirin, as long as they can tolerate it. That's usually somebody who has risk factors. They're diabetic, they smoke, or whatever the case may be, based on that risk score.
Okay.
But it's not a general recommendation. Everyone who's 55, not all of those people need to be on an aspirin. In recent data, I think last year.
I remember seeing a study about that.
That's about a year ago.
Okay.
You know, we kind of thought that to be the case anyway.
Yeah.
That's primary aspirin therapy for primary prevention. Primary means nothing has happened to you. Do you really need it?
Yeah.
And so that had been brewing for a while in the literature, and then we had the trial last year.
For some reason, I remember seeing some subgroup of people who are like between the ages of 50 or 60 or 55 and 65 or 70 that have certain things that they want those patients to be on baby aspirin, but I can't remember.
Probably risk factors. I'm not exactly sure what you're referring to.
But I like my phone, and I'm sure yours as well. When I would see patients, you can plug in a person's age, sex, cholesterol levels, all these kind of things, and blood sugar, what their fasting blood sugar is, and it'll give you a percentage of risk of having heart disease in the next 10 years.
10 years, yeah.
And what is your number? If they hit what percentage do you say?
7.5. Which
You're
is
a 7.5 guy.
which
Okay.
is given for statin
Okay.
as well.
All right. So yeah, most physicians nowadays have that app, and if you're chatting with your doc, they can look that up and just plug and chug those numbers, and it gives you a pretty good idea of whether you're okay to not be on a statin or whether it's something you need to be thinking about.
That's
So,
right.
yeah.
And that app is not proprietary. You can download it yourself. ASCVD risk score.
Yeah, we'll put that on our Facebook page and our website just so people can know what that is and look that up on their own. Final question about just preventative stuff, because that was one of our viewers asked, okay, what can we do to prevent staying
Yeah.
out of the cath lab? What if you had to pick a diet or two, or a diet? I don't like the word diet, but a certain way that you eat. Are there advantages to being vegetarian, being vegan, being a Mediterranean diet type person in terms of your heart disease risk?
Well, so I don't have, that's not my strong suit of being or managing diets, so I'll say that up front. So take what I say with this as not with a grain of salt, but I'm not an authority on dietary measures. In general, I can make recommendations about avoiding trans fats. Trans fats are pro-inflammatory. It can cause pro-inflammatory milieu within the patient that can increase your LDL, oxidated LDL, which is involved in the atherosclerotic process. So watch your trans fats and avoid those if at all possible. Avoid or limit the amount of red meat that you have, maybe once a week. Gravitate more toward leaner meats, turkey, fish, things like that. Veggies are always good. If you're a diabetic, watch your complex carbs. That will help reduce insulin surges that you can get with ingestion. And insulin surges are correlated with increased oxidative stress on the vessel, on the body, which increases its pro-inflammatory milieu, and that's what helps drive atherosclerosis. That's probably all I can say on it. That's usually what I tell my patients. And if they have further questions, I usually will direct them, I'll arrange a dietary consult for them.
Okay. Yeah, I know. My thought was always, if you could stay and have the stuff in the grocery store that's in the kind of along the periphery, are they out? So like other than the ice cream and stuff, but like if you could stick to the fruits, veggies, and lean meats, away from red meat, and try to keep away from stuff that's on the shelves. By and large, you're going to do better than the person who's not doing that. And let's face it, it's probably not it's maybe the stores, but probably more than that, it's probably all the different places that folks drive through and get fast food from.
Yeah, that's not good.
That's going to be a lot of these.
For me, I only do that when I have to. When I'm somewhere where there's no other good option and I have to eat, then I'll stop and get something. But if I have an option not to have fast food, I certainly won't.
Yeah, good. Dr. McKay, thank you. It's been good to have you here, and we have more things we can talk about. So who knows? In a few months, we might have you back, chat some more.
Great.
Appreciate it.
Thank you.
Yeah. Have a good rest of your day.
Have a good day.
Yeah, thanks. And I'm gonna let Dr. McKay is going to wheel out, and Chico's going to come on in. Here we go, Chico. All right. Hi, Chico.
Good afternoon, doctor. Thank
So
you for having
Chico,
me.
I'm always bad at trying to say your last name. How do you say it?
Alejo.
Alejo.
Yes.
Okay. All right. So Chico is the manager in our cath lab.
Yes.
He makes things flow and does a really good job with that. So I guess the first question I wanted to ask you, Chico, is besides having Dr. McKay and other heart doctors, what other folks need to be on a team for a cath lab to work?
A cath lab team is composed of, it's a multidisciplinary team, of course. You have your registered nurses, your radiologic technologists, and your cardiac specialists. All of them, of course, have specialized in the field of cardiology and the cath lab setting.
Yeah. How many of them are, so when Dr. McKay is doing an angiogram or an angioplasty, how many folks are in the room?
When a patient comes into a room, there's at least four other people in that room.
Okay.
Of course, you have your interventional cardiologist. You have your first scrub assist. Usually that's a rad tech specialized in cath lab.
Yeah.
He's in charge, of course, of the sterile field and the imaging quality. There is also a registered nurse who performs your moderate sedation and manages your medication, including
So
cardiac.
kind of makes you kind of chill out a little bit.
Exactly.
Yeah. Okay.
Yeah.
All right.
And then you have another member out in the control room, our physiologic monitor. His or her job is to make sure that, because everybody's of course concentrating on what they're doing, and
Sure.
this other person is kind of making sure
Overseeing kind of
yes,
the big picture kind
exactly.
of thing. Yeah.
Exactly. So he or she's monitoring hemodynamic status as well as he's managing cardiac calculations for the procedure.
Yeah. I think one of the places where your department shines, along with our heart doctors, is when patients have what's called a Stemi.
Yes, sir.
So, you want to talk about just briefly what is a Stemi, and when someone has a Stemi and shows up to the hospital, what's your goal for them?
STEMI, STEMI, is an acronym for ST elevation myocardial infarction. A lot of long names. Basically, MI, a
It's a heart
myocardial
attack,
infarction,
right?
is a heart attack. It is a serious heart attack where the blockage in your coronary vessel becomes so complete, and it happens so abruptly that a large portion of your heart tissue is not receiving blood flow. It requires immediate attention. The ST part of it was there because that's how we identify it. As soon as you come into the hospital and you are identified as having chest pain, they have an EKG on you, and on the EKG tracing, we can see if there's an ST elevation, and that tells us you're having an active heart attack.
Yeah, or sometimes that when the paramedics show up,
Yes.
they'll do the same. They'll do it and they'll send it to the ED, and they'll see that they'll tell you that they have someone coming in
That's correct.
who has that going on.
Yes.
Yeah, yeah.
Yeah, so identifying it as soon as possible is very important. So you are correct. If they can identify in the field, it helps us out a lot. So when a patient is identified as having a STEMI and they come to the hospital, we try. One of the recommendations to address this is coming to the cath lab for angioplasty and stenting, and we have to do it within a window. The recommended window is 90 minutes. We call it our door to balloon time. So as the name implies, as soon as the patient comes into the hospital door, we have 90 minutes to get that patient into our lab and try to open up that vessel. Now 90 minutes may sound like a long time, but in this situation it's really not. So a big chunk of our job in the cath lab is to make sure that we can come to the hospital first and foremost. We're on call 24/7. Get them to the cath lab, prepare them on the table, get everything ready for the cardiologist to start entering that vessel and opening it up. There are several processes we apply to it,
Yeah.
but the basics of it are very simple. It's practice, repetitive
Yeah.
practice. So we hone our skills so that we're as fast as we can, we do things as fast as we can, and we're as efficient as much as possible.
Yeah, because time is
Muscle, yes.
muscle. Time is muscle, and so yeah, and you guys do a really good job of making that happen.
Thanks, sir.
Yeah, for sure. What's the favorite part of the job for you right now? Would you say, Chico?
Oh, that's a good question. I've been doing this for coming on 15 years now. So
You don't look that old.
Oh, thank you. Appreciate it. But a lot of people say that at that point in time, there's a chance for people to get bored at something, especially if it's routine. And if it's a lot of practice, like I said, it's a lot of us doing the same things over and over again. Some people say that you'd get bored with that. Well, you see, the cath lab is one of those places where you do get a patient who's having a STEMI, a serious heart attack. They're afraid, they're in pain, they're dying. If we do our jobs right, if we do our jobs correctly, and everything goes as well as planned, after 90 minutes, that patient leaves our cath lab smiling with relief. And helping the doctors do that, helping the patients overcome their heart attack, that's the best part of the job. That's my favorite part.
Don't blame you. That sounds pretty cool to me too.
Yes, sir.
Yeah, yeah. Any shout outs you want to give to your team?
Oh, absolutely. The team here, the Cath Lab team at CGH.
I hear there's one employee named Belle that's really good. Right?
Oh yes, she's excellent. She's the best Cath Lab nurse in the world. She's also my wife. So yes, we have an excellent team here at CGH Medical Center. I see them and I see that they're very passionate about the job, just like me, and they genuinely care about their patients. So I mean, things have been hard for them, as it's been hard for everybody since this pandemic. But you can see that they are very dedicated to maintaining the service to the community, and I'm very happy that I'm part of this team.
Good. Make sure I have all my questions that, yeah, good. Chico, anything else you thought I was going to ask you that I didn't?
No, sir, but can I mention something?
Fire away.
When it comes to COVID-19, I know there are reports where patients, even when they're having a heart attack, because they're afraid of COVID-19, hesitate to go to the hospital or delay care coming to the hospital, even when they're having chest pain.
Yeah.
As you said, time is muscle.
Mm.
The seconds still matter. If you're having a heart attack, I think you should come to the hospital instead of being afraid that there is COVID-19 out there.
Yeah, that's a great point. I appreciate that, Chico.
Thank you.
Yeah, good. Chico, thank you so
You're
much.
welcome.
Yeah,
Thank you for having me.
You did well.
Thank you.
All right, great. All right, thanks, guys. I'm going to just wrap up here and just talk a little bit of COVID stuff. I have some questions from our viewers that I wanted just to let you know about. The first question that came, even before we started talking and broadcasting here, was can you explain the term herd immunity and its implications? So, yeah, herd immunity is just kind of the concept that if you get enough people that have either been exposed to an infection or have been vaccinated against it, then let's say you have 100,000 people and you have, 99,000 that have either had it or had the vaccine, then it makes it a lot harder for those people who are still susceptible to get it, because there's just not as many people they're going to run into who are going to be able to spread that infection to them. So that's the idea behind herd immunity, and that's the implication of it. For us here in this COVID world, the herd immunity is slowly accumulating, and then if vaccinations become available, that's another way to increase the number of people that would contribute to that herd immunity. I mean, that's classic. That's why we do vaccinations. That's when you hear about measles, mumps, and rubella, and there's like been an outbreak of measles. I think it was a year or two ago in a couple pockets in the country. It's typically because enough folks chose not to vaccinate that herd immunity wasn't as great, and so people who are susceptible and get exposed to someone all of a sudden start getting it. So that's the herd immunity concept. Next question was, is asymptomatic spread the biggest challenge to our ability to handle this pandemic? Good question. I would say it is a challenge. Biggest? I'm not sure that I would go there, but there's no question that, somewhere, I just read something today that this study said 40% of healthcare people who tested positive didn't have any symptoms. And I've read other studies where maybe 20% of folks. Anyhow, there's definitely a percentage of people who don't have symptoms who would test positive for the infection. And that is a challenge, for sure. From my perspective, I think right now, though, even if you were asymptomatic and had it, I think if you're wearing a mask and trying your best to kind of do the distancing thing and that kind of stuff, not that you wouldn't potentially spread it to someone else, but the risk goes way down. So once again, I think the asymptomatic spread is a challenge, but I think there are things such as just kind of getting folks in a rhythm about doing this distancing, masking, that can also help with that. And there are other things that are challenges, and there'll be more challenges, because as we move towards vaccinations, okay, who's going to get them first, which vaccines are the most effective. Do I want to get a vaccine that's one shot, or do I want to get the 2-shot one if the 2-shot one's available earlier? Yeah, there's just a lot of stuff, a lot of challenges. I would tell you, in the hospital side of things, it seems like every day, sometimes every week, but usually every day, there's something that pops up and you're like, oh, didn't think of that. Oh, yeah, well, that's something we need to deal with today. So they just keep coming. What did I have here that I want to make sure I had a question? Yeah, so numbers wise, I think you all probably are aware of this, but in Whiteside County, last I saw today, it was 725 cases, 20 deaths. At the hospital, we had 10 positive, just as an example, we had 10 positive results in the past 24 hours here at the hospital. So we continue to have cases here in the county. Our rate is 15 cases per 100,000 population, which is comparable, a little bit higher than Cook County, which is 12, a little bit lower than Clinton County across the river in Iowa, which is 23 per 100,000. So it's still there. It isn't as wild and crazy as you see up in pockets of Wisconsin right now or other places around us. And yeah, and I think it's going to be interesting. I think now that you're going to start reading some stuff about not just antibody testing. You've heard about antibody testing, and some folks, they do studies and they see what percentage of the population have antibodies to coronavirus, which gives us some sense of this herd immunity. And if you look at like a city like New York City, I've read that they've done the antibody testing on those folks, it's around 20%. So I think the thing that's kind of starting to percolate is there other ways besides antibodies that folks are developing immunity? Because in New York, where they're loosening things up, let's just say, the number of cases so far hasn't spiked up like you would anticipate. And there's something called T cells, that's T as in Titans, that also seem to be playing a part, and some people seem to have T cells even when they don't have antibodies. I was just reading an article today in the British Medical Journal, that's BMJ, it was from September 17th, and the question of that article was, do many people have pre-existing immunity to COVID-19? Something, if you're interested in this kind of stuff, you might want to just read that a little bit. I don't know that they came to a conclusion that's conclusive, but there's a lot more things to this virus that we're going to continue to learn over time about immunity and about how to treat it and those type of things, that when you look back at what I had to say now, what I said 2 or 3 months ago, we're going to go, what was he talking about? But we're trying our best with the information we have to make the best decisions and give you the best information we can. And that's how we're always going to approach this. So I thank for those of you who have taken the time to listen today. I'm looking forward to next week. And next week, oh yeah, we're going to have Dr. McGlone, one of our general surgeons, on, and he's going to talk some more about, we'll get into general surgery a little bit, but we'll also talk about breast health, about some of the work he does with that, talk a little bit more about the 3D mammogram that we have coming here to the hospital and how that's going to affect how he goes about taking care of patients. So I'm looking forward to next week as well. Until then, hope you all have a safe week, and thanks for listening. Bye.